anatomy. Okay. As you see here in this pictures, you see starting an epiglottis, lesser cornea, and hyoid bone, and the area between hyoid and thyroid is called the thyrohyoid ligament. And there is what's called an thyroid cartilage, which have an Adam's apple or larger prominence, which can feel in male. And there is an ligament again, it's called cricothyroid ligament. And usually cricothyroid will go to this ligament, cricoid cartilage. And this is the only continuous ring, because the other ring, the small ring, is continuous anteriorly, but posteriorly not continuous. So, and this picture to show, I don't want to go for blood supply. I just want to show you that the center of the neck is dry, don't have a very big blood vessel like peripherally. And this is very important to us. And also in anatomy and sonoanatomy, and even in landmark technique, you can appreciate thyroid cartilage. Cricocyte membrane, I can feel it, but in some obese people, it's really very difficult. I can feel and see the cricoid cartilage and thyroid gland, and also tracheal ring. The nerve supply of the upper airway came from trigeminal, glossopharyngeal, superior laryngeal, cantolaryngeal, which came from the vagus nerve. So the main supply given what's called the vagus nerve, we give two branches, superior laryngeal, and they give internal and external branches. Very important just for anesthesia for the upper airway. And the current laryngeal given part below the vocal cord. And all the time, what we can appreciate in ultrasound, thyroid cartilage, cricoid cartilage, esophagus trachea, we can see all the structure in a better way. And also, all the time, you see this picture when you put an esophagus behind the trachea. I found this in every book, but in 90% of the case, you can go just if it was ultrasound, you found this in the left side of the trachea, not just below the trachea. And you can appreciate it, the ultrasound, you can appreciate it, the esophagus and swallowing, and you can see it because very important during intubation. Sorry, I introduced Mr. Langi, and Mr. Langi will just get the journey with us all over the trip for the presentation. And I think you're not happy because I don't present him in the beginning of the presentation. And now it's okay, agree that I will introduce him, and he's happy about that. So why ultrasound in everything of the airway? Usually I ask this question in airway and regional anesthesia, in ICU, in emergency. The first thing is this, I found this paper about 2 years ago, published that are using ultrasound system to guide procedures. They found the people answer, all physicians from different specialty, answer about 85% of the people using ultrasound for one of the procedure in his specialty, whatever ER. And also, this indicates about 2-3 years ago, but now I think the incidents become more and more for the advanced technology. This is the first ultrasound done in 40s, late 40s, and if it stay like this, water inside, put the patient inside, I think we will not come here to discuss about this issue about area and ultrasound. And you know that the technology advanced very fast, like a mobile phone, and even ultrasound every day you can find a new thing. I don't scare Mr. Lange from this an old one, because you have a new one like this one of the machine, like a barcode machine. You can just use the probe like an barcode machine, and every single display from the tissue on the machine. And after that, it come what's called wireless probe, like an dual probe, one straight and one curved. You can use with any machine or any display like mobile phone or any smart machine. And after that, it comes this one. So it comes, that was called, sorry. This is a machine with color ranked ultrasound, and also they have artificial intelligence, like the machine we see before. And sorry, this machine, like a machine we see before in Ahmed Maher, they have artificial intelligence. The only advantage of this ultrasound, you can see what's inside the earth without digging, and what's behind the door without opening. And this is a very good advantage. The main advantage also, you can see what's called like a video. It's called frame frequency, 7,000 cycle per second. So I can see a video, like a video. Machine, you can see a video. And if you see a video by sea arm or radiation, you pay a taxes from hazards which you get from radiation. And when you started, I like this picture. When you started your career in ultrasound, what you see in the display, all the same, no difference between any structure. But after some time, when you know the character of every structure, you can discriminate between the structure. I know that every step you go, you have a difficulty. But if you are patient enough, you can be a professional soon. And you must have a second plan all the time. Don't go for any procedure and advice without have another plan for. This I found this joke and I like this joke before, so I gave it for you. When I drink alcohol, this gentleman he said, when I drink alcohol, everyone see I am an alcoholic, and when I drink Fanta, no one says that I'm fantastic. So this man from India just make a funny comment. I said, because you look like Coca-Cola, my dear. It's not a Fanta. So whatever you have a very big neck like this, a heavy neck or just long neck, you know that ultrasound can help you, whatever the case is it. So sonography of upper airway, you can just assessing the airway in a perfect way, especially in a people with a heavy airway or heavy neck, which have a character neck on the shoulder, don't have a, sorry, head on the shoulder, don't have a neck. And this can help you a lot because you can tell me, I can landmark technique or I can feel it's okay, but for most of the people, we can do that. So the verb usually we use a curved one for a heavy person or heavy net, and a straight one for a linear one for the superficial structure. But you must remember there is a difference between ultrasound anatomy and what's called an sono anatomy. So this is my picture 10 years ago when I was still young. And this is my picture again 10 years ago also. But the difference between the two is one anatomy and also no anatomy. So I guess you can't know the whole gentleman in the hazy picture without knowing the anatomy. So knowing the anatomy is very important. And I think Mr. Lange was not happy with me when I speak about anatomy because I forget to tell you that the trachea ring in most of the people from 18 to 22 ring. And again, the trachea usually in most of the people length from 12 until 18. 18 is like a Hollywood actors want to have a very long neck like the gentleman. But mostly it's about 12 centimeter to 40, and half of this trachea in the chest and half in the neck. What is the point of care ultrasound for airway? First thing, it facilitates the endotracheal intubation and also to assess the depth of trachea. How can we do that? I will show for you. This picture, I was in my one of my block room, and this my colleague Timur, and thanks for Timur because he's a very good volunteer. When I needed to take a picture, because I don't like to bring a picture from the internet, and most of the time I bring it from Timur. And thanks for Timur for all this. For all of this, sorry, and pictures. And is a very, first thing you can see the thyroid in the scan and thyroid cartilage and this trachea like a inverted horseshoe. And no, I can't. Mr. Lang asking me to put a tube for Timur, but I can't because this is just a volunteer for the scanning. And here you can appreciate all this structure externally. You can see all, the most important for us is hyoid bone, thyroid cartilage, cricute cartilage. Even I can feel, sorry, even I can feel it, but not in every patient. Although I can appreciate in the middle, which is derived from blood vessels, all this structure, because this will come soon to tell you about how can you assess ultrasound by the care. So the first picture from Timur, it was an thyroid isthmus, air mucus interface, and inverted horseshoe appearance. Again, this is from Timur to show the esophagus. As I tell you, usually in this screen, usually all the time, most of the time is from left side, but sometimes I found in right side. So here, yeah. So this is the esophagus like concentrated structure because we have an importance in suprasternal nodes when we just make an intubation, difficult intubation. So I just give this video, a small video. I'm sorry. This is esophagus and his swallow again. So now I'm just going a little up to see the cricoid cartilage, which is a very big cartilage. When I go down, it's small cartilage, not like this one. Here I just go a little up in the above the cricothyroid membrane because just after the tracheal, the cricoid cartilage, what's called cricothyroid membrane, which is a membrane for just a cricothyrotomy. And this is a strap muscle on the lateral side. And remember, in the middle is dry and the bleeding is very little. Again, if I tilting the probe up to look from the thyroid, I can appreciate this V-shaped structure with thyroid, but I can also appreciate the focal cord and it can move with speaking. So I can use it for a case of thyroid without removing the tube. You know that I can leave the tube or install it. What's called exogenous silent, and to see the vocal cord moving or not for the this medical legal aspect. If I go up and I can see the hyoid bone, and really, I don't have any now and up till now the very big importance about that because we have no many nomogram about and score about difficult condition assessment by ultrasound, but still up till now no validated stuff. And this is one of the stuff he can just examine below the chin to see this important structure, but I will not speak about it because there is no up till now a validated score to assess the difficult airway by ultrasound. But also I can appreciate here, that here in this one, you see the small tracheal ring, and this is the biggest cricoid cartilage and thyroid cartilage, and in between the cricothyroid membrane is about 1.5 centimeter to 2.5 centimeter. And again, if you look here, you found this like a ring inside the trachea, this artifact. And this is very important when I just make a mark for cricothyrotomy. And again, this is a picture. You can see appreciate the picture here. Sorry. Appreciate the picture. This is a cricoid cartilage, the bigger one, and have an artifact usually. Cricothyroid membrane about 2 centimeters, and thyroid is a very superficial because higher and also more dark. You can see below it because the cartilage here is very thick, look like a cricoid cartilage. You know, I will just go for this because you can measure the distance, what's called pre-esophageal epiglottis distance. And epiglottis distance, this fat, you can just make a nomogram for difficulty for the airway, but still not validated, and you need a time for that. So the indication for ultrasound, for any tracheal intubation, you can assist. Anticipated difficult airway intubations, you can make a mark for the surgical airway to be ready. And certain, what is that tube, esophagus or trachea, or even outside. And preparation for surgical airway, just to be prepared, to be ready when if you suspect a difficult intubation, just to make a mark like a surgical airway. If you get in hard time or troubles, you can put just a needle inside. To tell you this fact from emergency, that esophageal intubation is 6 to 16%. It's a little higher than the anesthesia, but anesthesia maybe because of training and suitable condition and not urgent all the time. But it's a very big number of cases when you put in 6 to 16 in emergency in esophagus. And the problem, if you put in esophagus, this can lead to significant mortality and morbidity, even this. And you know that because of that, we need something to decrease that, to tell us about the what is the tube. Using ultrasound real time also sometimes can improve the tube inside the trachea or not, and the depth, especially in kids. Pediatric, very easy to see the trachea and to adjust the trachea because you know the trachea is very small, very easy to go right, left. And this is, I show the picture later for that. But you know, using ultrasound, what's called as a real time, it is a safe, easy, rapid, accurate, and cost-effective tools. So what is the method to confirm the position of we have many methods, and some methods is very famous. The first thing, to see the tube and to see your cuff when put it in the between the focal cord. And this is one of the sure sign if your eyes is good. Again, carbon dioxide, but sometimes unreliable. Sometimes take a time just to be clear from the stomach. If you inflate the carbon dioxide in the stomach, or the patient get a carbonated water came from accident, it can mislead you. Again, auscultation, but sometimes in difficult situation, noise monitor, noise for resuscitation, sometimes unreliable. Ultrasound is you can catch that you put a tube in the tracheal esophagus in 9 to 40 seconds. So it's a very accurate method, and you can make it easily, and it don't need a very big amount of training because just you need some physician who can see. And the other method, I will not speak about it, about chest movement, all the other stuff. So if you go for direct visualization or auscultation or chest rising, sometimes unreliable, sometimes we can't see the tube to go inside. And if you go for in the carbon dioxide, in the tidal carbon dioxide, sometimes delayed to see that you are not in trachea, and sometimes unreliable if you put in tube in stomach full of carbon dioxide or carbonated water. Chest X-ray, it need to stop, and it need the result will come late to see the tube inside or not. Fiber optic, not everyone competent for fiber optic. And fiber optic in a major situation, it will be very difficult to put a tube. So this is an interesting study from Gisar et al. In anesthesia 2009. You know that he was scanning what's called an in the hospital, an appropriate tube, sorry, position, it was less than 2 centimeters from the carina. He defined this inappropriate. He found about 20%, because, you know, ideal position to be 2 to 4 centimeters from the carina. And again, bronchial intubation from 5 to 8 for all intubation tubes. And this is a very high number, and this can kill the patient. And also, you know that now, as it was an auscultation, it started as a confirmation of the tube from American Heart Association, but now putting one line about ultrasound, because it's coming. So auscultation, this is a very interesting study about Sotozo, and use of auscultation to distinguish between tracheal and surgical intubation is unreliable, and with sensitivity only 60 to 65%. And this is a very alarming thing, you know, very alarming about the sound which came from the trachea. So 60-40%, this means that every 10 patient, 2, 3 or 4 will be died because the tube will be on surface. An emergency and resuscitation, very important. Do an ultrasound. And in my hospital here, I train my colleague, my junior staff, to put a tube, and in normal patient, I put an ultrasound in the trachea, and I tell him put in the esophagus to see the picture, and put in the trachea to see what happened. So always protect your tube, because this is main job, our job. So in emergency situation, have a special what's called situation, and usually ultrasound examination of tracheal intubation, if you measure carbon dioxide monitor, sometimes not accurate. Radiology is not available all the time to take a picture and to see the trachea inside or not, and not dynamic. And sometimes the patient arrived intubated, and you need a confirmation, because, you know, AMS people, emergency people, or ambulance people, not professional enough, like a physician, they put a tube. And also, sometimes if the patient don't bring a return of what's called a normal circulation, sometimes you don't know that there is no carbon dioxide because of the patient perfusion is low, or it may be an outside. So this can guide you in very brief way. The perils here, you know, if you wanted to make for difficult airway, for emergency, if you have a time, you can make breath scan prior to see everything about airway, if you have a time. And to put a mark, to see the esophagus is collapsed. And you know that, you know, the best way to see the trachea and the esophagus in the just above the suprasternal notch. And also you can assess pre and also intubation, what happened for the trachea, what happened for the esophagus. But the pitfall, the problem here, we have a problem with everything. The pitfall, sometimes we have a variation for esophageal position. Sometimes you see behind the trachea, and you put a tube and you can see what's behind the trachea. You don't see the sign, what's called the goose sign or double tracheal sign. Sometimes you can see it. And sometimes you have a neck tumor or mass, so it will be very difficult to see through this one. And maybe have a trauma like this lady. You can't put a probe anywhere. How can you put a probe? And again, sometimes you have a calcification of thyroid, which mimic other structure, give you shadow below it. I just give me this many time, but I don't know someone know this picture diagnosis, but I think Dr. Safa know. I think his wife knows the password of his mobile phone. It's a very common spot diagnosis. Now, Mr. Langel was on sleep all the time, but now he's laughing about my silly joke. Again, here, you need how to confirmation to know that the tube is inside the trachea. First thing, with ultrasound suprasternal notch, when you inflate the cuff, you found that the trachea is dilated. But sometimes you tell me it's not a proof for that. It may be something else. So I can make what's called color Doppler. When I make what's called movement of the balloon, you can see like a mosaic shape when you put a color Doppler. Again, if you injected saline inside the tube, if you injected saline, sorry, inside the cuff, but we need an agitated saline. We need some particles of air. You can just take the saline, inject it in the cuff, and you can see that. If you inject it, you can see the moving particles of air inside the trachea. And also, when you inflate the trachea, you know, it's like a horseshoe appearance. It changes the shape to be like a bullet. You know, and no absence of double tracheal sign. I don't see that double tracheal sign. This means I don't put the tube in the esophagus, and mostly in the trachea, except if the patient have a false passage and edema. And you see also after that, you see lung sliding, pulsation, ventilation. You need to see the ventilation of the lung. So this is how to can prove the trachea inside. Sorry. And here you can see the appreciated trachea. Here's the trachea, but when I put in tube inside the esophagus, make like a stenting, so it will be like a double tracheal sign. And you know that this is a very sensitive, very sensitive. Sorry. So this in this paper by Maslow et al. In 2011, evidence of ultrasound detecting esophageal or tracheal intubation sensitivity is very high, 100% in OR. It may be less in emergency because of the noise, but 100% sensitivity and 86 sensitivity in CPR, because different in CPR, but at least you can know this 100%. We don't get anything in medicine 100%. Again, you can see here appreciated what's called double tracheal sign. It's a normal trachea, it's esophagus, and tube inside become like a stenting like a trachea. So if you see this picture, this means that the tube in esophagus. This is a trachea, it's esophagus. Again, here you can see appreciate here what's called an. You see the trachea when I inflate the balloon, you can just dilate it like this, So again, this is the shape before to put the trachea here. A normal, when you put a tube, become like a bullet sign. You see the different picture, but sometimes you tell me I need a very good eye to see that. But I will make it for you. I can see here the vocal cord moving. Now I can't see anything here because even the vocal cord is masked by, the structure and also by the tube. Again, those called the bullet sign. It can make a bullet sign, like a bullet sign when you put a tube inside. No, this is one not sure, but I have many things to tell you about it. You can see here trachea, esophagus, and I put a tube in esophagus. You see what happened? You see, look here. When I put a tube, it become like a stenting, immediate dilatation, and it become like a, you see, like a double tube, a double tracheal sign. And also, if you make a shaking or the movement of cuff, you can see what's called artifact here, and mosaic shape artifact, and here's the tracheal also dilated. So when we speak about esophagus and tracheal embrace and what is the method and what is the validity or specificity, you can find sensitivity about 98%, very specific also, very high. I can put in 9 seconds, in some study for 40 seconds, but for us, I found 4 seconds, sometimes 4 seconds to know. Noise dependent as a pro, and circulation independent, but the cones dictated provider and machine. You need a special provider and machine to assess and to see the ultrasound. You know that easily you can go for this one. And when you see this lung, it's a cometal appearance. This is what's called an hyperocclusive structure for pleura, and this moving like this, and sorry. So if you see this picture, it's a normal for the person. But if you have air inside here, you don't see the sliding pleura and you don't see the comet tail because air isolating the lung, you can see. But sometimes you see the pleura not sliding and you see the comet tail appearance, but not moving. So how can they differentiate between pneumothorax, for example, and non-ventilated lung? We'll see. And this is a line when you see in ultrasound. This is a pleural line, and we see like a seashore appearance, like a wave, barcode down and up and sand down. So in this picture, I can show this structure here. The pleura is moving all the time, cometal appearance. We don't have air or anything inside. So now I just will show this for you, this video. You see the sliding pleura here, and this is the rib, and there is cometal appearance and fact. And I need just for you to look for the other picture. The patient is ventilated, but it's not moving. You see? And I can just go to see the area of moving lung. So now it's moving. and this area not moving. You see, moving, not moving. This is the separation for pneumothorax. But again, I must be sure that the tube inside, and this is a pneumothorax. How can pneumothorax? Because there is other thing. I put an like and I see the waves here for what's called intercardiac oscillation. So if the heart pulsating and transmitting the wave to the lung, so I can see this pulsation. But and this means the lung non-ventilated. But if I see lung not ventilated, pleura not moving, lung not ventilated in the right way, and I see this pleura not sliding, and I don't see cometal appearance, this means the pneumothorax. So, and there's other tests when you use what's called M mode to see the motion. If I found this picture, like a barcode here and sand down, it's called seashore appearance. So if you are in sea and you see the shore, you are safe. And this is the same. And the lung is moving in a better way. But if you found all the picture like this, is a difference between sea, shore appearance. This is the sand, this is the waves, and this also all barcode. If you don't found this, when you put your M mode on pleura, this means one of two. First one to be pneumothorax. Second one to be a non-ventilated lung. How can I know? You see this pulsation? This one too. I will show for the other one. This pulsation says this is non-ventilated lung. This is barcode and no waves here, so it is a pneumothorax. Here I can show for you. That I have not moving lung and I have nothing moving. So, and I just will go for this pulsation. You see, this is the intercardiac oscillation, can transmit it if you don't have air. But if you have air in between, this will not transmit because air not transmitted ultrasound wave. And here to the picture, this is the patient non-ventilated, and this is the wave, you can see it. So usually look for the tube when you put it. This lung not ventilated or ventilated, or the patient have a pneumothorax. And there is a very good ability to discriminate even the surgical intubation and to see the tube depth and at the same time lung ventilated or not. And because of that, the American Heart Association put it in their guideline that when this esophagus can be showing the correct position, and we need more data to be more sure for the guidelines. Here's the trachea, and this is cricoid cartilage. Again, to remember, this thyroid, you don't see anything down. It's very thick cartilage. You can't see anything down. It's called the shadow. Here, I can shadow down here. And this is a cricoid, the biggest trachea ring. So a cricothyroid membrane. How can I make it? And sorry. So I make a mark first by cannula or any needle. I make like a target when I need it very fast in emergency. But sometimes this is a needle. My needle is a cricoid cartilage, sorry. And this is a thyroid up. So this is a very good area to go inside. And here I put my needle here. So it can make a mark to go easily. I will tell you a story happened to me. And I know that they called me one day on the call, and one of my specialists told me that the patient was planning to make tracheostomy tomorrow, but the patient is suffocated, saturation is 50 and 100% oxygen. And we need just to make it right now. So I go to the hospital. What I found, the patient is struggling for breath, blue by blue. And they tell me the tracheal stenosis after blocking the session. But really, I don't convince it about the diagnosis. So with the surgeon, I tell him I can put a needle for you in 3 seconds. Give me 4 seconds. He tell me no, because we dissect the neck and neck is empty, and we know that previous tracheostomy you can put a tube very easily. I told him this is a tumor and recurrence. And that we stay 26 minutes struggling for that, and the patient arrested and put a tube in tracheal tube. It was 5.5, and if the tube 5.5, the patient can take his breath in better way. But and 26 minutes until put the tube in the trachea. He opened the same plane and they found put a tube and tumor necrotic tissue coming outside and bleeding and horrible thing. So at the end, I speak with him as a very gentleman about the guideline, to put a guideline for a case like this. Give me 5 minutes to put an ultrasound and to put a needle for you, to guide you. You can make it and very easy and very simple. And after that, we found what's a collapsed lung from the bus in the lung, make a cast, and we try to make a section until the saturation become 100% for this patient. All the time, just to go now, not by logic, not by belief, because not all the logic is science, and not all the science is logic. So many things is not logic. So we're looking as an evidence in everything. So according to recent study, marriage is the main reason behind divorce, and everyone I think agree with me. But in ultrasound, it may be a little different because you need an evidence, you need a time, you need to make a human study, not animal study. You need a randomized control study, you need meta-analysis, you need a big thing, and we don't have this one. So you must remember that absence of evidence is not evidence for absence. And at this time, you go for the expertise to asking, and the expertise opinion is a very low evidence, but this is what available evidence. So here a tracheal what's called rapid ultrasound examination and confirming the tracheal intubation. And he found this 95 tracheal intubation. He found about 17 esophageal in the emergency, and this can give you high sensitivity to put a tube in the right way. A pilot study evaluating for accuracy of ultrasound confirming intratracheal intubation is the same. He gives the same result in even 100%. Here also ultrasound for airway management and evidence-based review for emergency clinician. Airway management is a core skill in emergency department and even in anesthesia of in anywhere in ICU. And BOCAS can be a valuable tool in airway assessment and also in dynamic tracheostomy. Ultrasound evaluation in airway and visibility study, the same result. It's a very good tool, can save your life, can be can what's called and save the patient life all the time. Again, role of ever airway ultrasound in the in ultrasound, but just I live here that ultrasound useful in critically ill people because it's non-invasive, effective reproductivity, promising increased number of the existing evidence every day, and also airway thinking seriously about to make a scoring system for the airway for assessing the airway. Also, ultrasound airway and ultrasound for airway the same result. Here, I just in everything in ICU and anesthesia, even in vascular area assist, so even in everything have a role. And now I found all my colleague in it was called junior resident. Everyone have a probe a wireless in his pocket, and they want to examine anyone just in the emergency or anesthesia. I just put a probe using his mobile phone or anything. But this is the ultrasound anesthesia present and the future. But I will just read for you last row from this one. He said soon me need to carry a portable ultrasound, every physician, whatever is the specialty, around their neck instead of the scope. And this happened already. At the end, I just will give you the scenario which happened. Sorry, just a fact, point of care ultrasound for airway. This is 72 years old woman presented to ED department after a cardiac arrest. She was intubated prior to arrival in their house or street. The pre-hospital team stated that the intubation was difficult. Capnography didn't demonstrate a good wave. He gave some wave, but not a good. Unclear if the tracheal tube inside located, or this is because of poor perfusion. No carbon dioxide came because of the cardiac arrest. You wonder if the endotracheal tube in the current position or not. When they bought the ultrasound, what they found? Yeah, I will show for you. When they put the ultrasound, the patient came like this and looking for ultrasound. What did they found? They found this is esophagus and this is trachea. It's called ghost sign or double tracheal sign. They put the tube in the trachea. Even the patient, for a long time, I think this is still inside. Not sorry, they found that the tube inside the esophagus. It's okay. So I know this time not over, but everyone having something to do. Even I'm squeezed here. I'm just delay the dinner of my colleague here. They're waiting for me. They'll not go outside. And some people waiting for me to finish. And even Mr. Lange very happy because wanted to finish fast. So this is my sweet conclusion for you. Airway ultrasound are summarized as follow. Prediction of difficult airway, confirmation into the tracheal tube, placement and ventilation, prediction the size of tracheal tube. So there is a no score just to assess how much is the tube you need, but it need a validation and need more study. And also prediction in tracheal tube, even tracheostomy tube. Also assessing and the guidance for proper percutaneous dilatation, tracheostomy and the cricothyrotomy. And also, you must know that training and the blade of the airway sonoanatomy must have some training to know the airway anatomy, how to make a sonoanatomy. Nothing coming without and training. and to make a confirmation of the intratracheal tube placement. Question is still not answered. Many questions not answered because a new era for that. And until we answer this question to get a cemented data, we still hesitated about something and looking for guidelines. But unfortunately, guidelines is not an obligatory like policy and procedure. And the guidelines sometimes is changed because not built in high evidence all the time, opinion of expertise. And you must remember that no one fit all, nothing can fit everyone. And we are still in the infancy of research. And we're looking for the future of ultrasound. So we need more study to cement our data about the ultrasound airway. And just never stop learning because life never stop training at all. And this Mr. Lange, he get tired, not happy, and I tell him bye-bye forever. And thank you very much for attending and for your time. And this last slide is my communication for any thing about the subject or other subject. You can take my personal or official email or just phone. And don't be sad if I don't answer you. I just send me an WhatsApp message. Thank you very much for attending and for any questions, for any questions.
Thank you, Dr. Yasser, for your distinguished lecture. And thank you for your endless support and endless effort to spread and disseminate the valuable knowledge for our colleague in ISAC. Till now, we haven't question. It was very clear lecture. Dr.
It's one of two, maybe very clear or no one interested.
No, it is very clear.
Okay, it's okay.
It's very clear.
Thank you, Professor, for this very informative presentation. I'd like to say that maybe the best combination is the video scope plus the ultrasound or the airway ultrasound. Maybe the video scope will be supraglottic for the confirmation of the endotracheal for the intubation. And the ultrasound will be subglottic regarding the cricothyroidotomy, if you want to be sure that you are in the lung regarding the absence of the double tract sign. Also regarding the ventilation of both lungs or the endobronchial intubation in confirmation regarding one lung ventilation, or to take the tube out. Do you agree with me?
Totally agree. Just if you have more tool to help you, agree. For example, when I started to make a percutaneous tracheostomy, I was not we don't have a fiber optic to use it from inside or ultrasound. It's not an ear. Like you feel the trachea between first and second trachea ring. I put an introducer to inject some local inside and leave the needle, and after that I bought my cannula, guide wire, dilator. But in what's written in the literature, alhamdulillah, I don't see it. That you can make a posterior tear for the trachea because you can see. So when they bring an fiber optic to assist you when you put your needle to see the needle from inside, it was a very great achievement. But still, in some patient you can't feel. This is a problem, and this is the role of ultrasound at that time. But when you make it for a difficult case, you will not lose anything if you make a very easy case. Because today I just have a people just in back, something like this in back intervention, and one of the lady put it on lateral, it's called oblique view, and put the needle near the foramen, the transforaminal, and again they make it lateral view. It was a perfect in oblique, and so I tell her I must make an posterior anterior view. What I found is they enter by the needle in the spinal cord. This is going to middle of the vertebra. This is what I mean. You need more tools to give you more perfect and value for you, and I agree with you, but we still don't have enough data to say about anything,
So the video scope still wins.
Yes. What? This is not a winner or not winner. Sometimes it's very more difficult, and you can see the trachea. It may be need an ultrasound to tell you fast where is it you. So it's still valuable, but everyone in the future have a role.